Welcome and thanks for joining our rapid fire video on digital mental health technology or DMHT. I'm Reema Taneja, Senior Counsel at Nixon Law Group, where I've spent the last 5.5 years advising healthcare innovators. I'm joined today by my colleague Michael Schellhous, who is an expert in all things digital health, including overall FDA compliance and other regulatory issues that apply to DMHT, our topic for this video. Our firm, Nixon Law Group, as you may know, focuses exclusively on healthcare innovation, and we get to work very closely with founders who are building some of the most forward-thinking solutions in digital health, making DMHT an especially timely topic. So for this video, we are taking a quick look at DMHT, the codes, what they cover, how they differ from the remote monitoring codes, reimbursement, and where some of the current limitations are. We'll also touch on why, despite some hurdles, these codes represent a major step forward for digital health innovators. Before we jump in, here's just a quick disclaimer. While we are lawyers, we are not your lawyers unless you've signed an agreement with us. So today's video is for informational purposes only, but we are always happy to answer questions afterwards. All right, so we'll start with question 1 for Michael. What exactly do the DMHT codes cover, and how are they different from remote physiologic monitoring, or RPM, and remote therapeutic monitoring, or RTM?
Thanks, Reema. So the DMHT codes that we have are really intended to cover the delivery of a mental health treatment intervention that utilizes a digital or software-based device. This is fundamentally at its core different from the RPM or RTM codes that a lot of people are more familiar with, because those codes at their base core are intended for a more passive monitoring of a patient's condition over time, rather than direct delivery of a clinical intervention like we see with DMHT. Because of this, the reimbursement is a little bit different. So with the DMHT codes, because they're intended for that delivery of a specific therapy, they're intended to cover a single course of treatment of that therapy, rather than the more month-to-month reimbursement that we see with RPM and RTM.
Got it. All right, question number 2. What are the requirements for a device to be eligible for reimbursement under the DMHT codes?
The eligibility requirements that we see here for DMHT are a little more stringent than for RPM and RTM. First, the device needs to be FDA cleared under one of 2 very specific regulations. These regulations currently cover indications for depression, anxiety, insomnia, substance abuse, and most recently in the 2026 physician fee schedule, CMS expanded coverage to also include ADHD as a covered indication. In addition, the device needs to be ordered or prescribed by a billing provider incident to that provider's delivery of professional services in an ongoing behavioral treatment plan. The patient needs to be formally diagnosed with a mental health condition. The provider needs to incur the cost of providing that device to the patient, and the device can only be used with the FDA cleared intended use, meaning we can't see off-label uses being reimbursed for mental health care yet.
And our last question, what are the biggest limitations or pitfalls in the current DMHT code structure, and what changes are stakeholders pushing for?
There's a couple major pitfalls or challenges that we're currently facing. The first one is that eligibility requirement that the device be FDA cleared under those specific regulations. It creates a very narrow area that devices can be eligible for. And so we see a lot of device companies working through the strategy of how do we get reassessed into one of those regulations, or how do we take a device that was operating under enforcement discretion previously and now seeking that FDA clearance for those regulatory codes. The second is that in establishing the DMHT codes, CMS didn't set a national payment amount. So they kind of continue to struggle with the idea of how do they tackle purely device or pure software products that don't really fit into the traditional way that they evaluate cost for reimbursement purposes. So instead of establishing that payment, they deferred reimbursement to contractor pricing with the individual MACs or Medicare administrative contractors. What that means for device companies is that if they want to utilize these codes, they have to go to each of the MACs and negotiate individual reimbursement pricing in each area of the country according to what MAC it's in. That can be kind of a cumbersome process and has delayed utilization quite a bit, but we are seeing progress made there. Lastly, I'll just note that we are seeing some pushback from providers simply because many mental health care providers aren't used to having to furnish the cost of a product before they give it to the patient. It doesn't really fit into the way that they normally operate. And so there's continued push for education and reinforcement with providers to get them more comfortable with the process and kind of push it over. But overall, despite these hurdles, as you said, this is a huge step forward. We are seeing massive movement in this area, and we continue to see stakeholders push conversations with payers, with providers, and primarily with CMS to continue the conversation of how do we expand coverage for these to additional indications? How do we push back against these barriers and really make a difference in the market? These devices are making a huge impact for the people that receive them, and we want to continue that momentum forward.
Definitely. All right, so that wraps up our overview of DMHT. Thanks for joining us. For more resources, you can visit our website, which is linked here via the QR code. Or if you have any specific questions, please reach out to us at this email address on the screen. We look forward to continuing the conversation as this space develops.
Thank you.